Hello and welcome to lecture 3 of the Understanding the ECG lecture series. My name is Phil Lecam and I'm a cardiology registrar. This lecture will be talking about heart block. So there are only 3 learning objectives for this lecture, which is shorter than the first 2. One is to be able to describe what heart block is. Second is to be able to recognize the differences in ECG patterns between the different types of heart block, and finally it's to understand the clinical significance of each of these forms of heart block. So as with the other lectures, I'm going to start by just recapping how to read an ECG. This is a quick walkthrough, and if you need more detail than that, I would strongly recommend going back to lecture 1. So we start with the details available about the patient and why they've had the ECG done. A quick look to see whether the ECG is calibrated correctly, how fast is the heart going, what rhythm is it in, what the overall cardiac axis is, and then going through each of the waves and segments. So looking at our P wave, particularly thinking about its size and shape, and whether it's positive in lead 2 particularly, whether the PR interval is normal, whether the QRS complex is appropriate in terms of its breadth and amplitude, and then the ST segment, particularly thinking about ischemia or infarction, which we talked about in the last lecture, and finally going on to the T wave, looking for any signs of inversion. So what is heart block? Well, it's actually a group of conditions which affect the electrical conduction system, and essentially what links them together is that they in some way impair the communication between the atria and the ventricles. But they can do that in slightly different ways. And there are 3 major forms: first degree, second degree, and third degree, also called complete heart block. And as you can imagine, as we go further down the degrees, things get worse. This is principally a problem with either the AV node or the bit just beneath the AV node, the proximal His bundle. And as I said, as we go from first to second to third degree, it gets steadily worse for the patient. And they may need a pacemaker. Normally with first degree heart block, actually, you don't really need anything. But by the time you get to complete heart block, you certainly need a pacemaker. So let's talk about first degree heart block. So here's my diagram of the heart again. You'll see that the atria and the ventricles are essentially electrically isolated from one another. And the AV node here is the only connection in most normal hearts between the atria and the ventricle from an electrical point of view. So we get a normal heartbeat, we get the sinoatrial node triggering off, we get our P wave, which is our atrial depolarization, coming into the AV node. And it sits in the AV node. And then after a significant or an appropriate delay, we then get ventricular depolarization with our QRS complex, our ST segment while we're in the plateau phase, and then ventricular repolarization. Now, this can be slightly different in first degree heart block. We still get our heartbeat coming from the sinoatrial node, we get the atrial depolarization, and it gets to the AV node. And then, so we've got our PR segment here. What we see is that actually in first degree heart block, that PR segment, or that PR interval as a whole, is prolonged. And that's just because it's taking longer for the signal to get through our AV node. But it still gets through each time and leads to ventricular depolarization. So all you have compared with a bundled normal ECG is this prolonged PR interval, longer than 200 milliseconds. Exactly as I've shown here. And that's this delayed conduction through the AV node. So I think the key thing is that P always precedes QRS and QRS always follows P. And the QRS complex should be normal, or at least certainly it's not going to be abnormal because of this heart block. Okay, because the signal is still using the conducting system that goes into the ventricles, still using the His-Purkinje system. Now, if the person has, preceding bundle branch block, which we'll discuss in the next lecture, then they'll obviously have that if they develop first degree heart block. But in and of itself, the first degree heart block does not change the QRS complex. And it's just this stable, prolonged PR interval, so it's greater than 250 milliseconds, and it's the same beat to beat to beat. So it's just the same PR interval that's longer. So here we've got a single lead of an ECG that I've pulled out, and you can see they've quite clearly got P waves followed by a narrow QRS complex. If I pull out one of them, we can see here that that's at least 6.5 small squares in length, that PR interval, so it's really quite prolonged. So why do we care about first degree heart block? Well, generally it tends to be a non-progressive condition, and in and of by itself it's actually pretty benign. Now, if somebody suddenly starts getting first degree heart block and actually it's starting to get worse hour by hour, day by day, that's something that might suggest endocarditis. You can get an abscess of the sinus of Valsalva right by the aortic valve, which presses on the AV node. And this is something you should be getting regular ECGs on patients, certainly in the initial acute treatment phase of endocarditis, if they've got endocarditis of the aortic valve, because this is a recognized and serious complication that you need to look out for. First degree heart block also doubles your risk of developing atrial fibrillation. And it makes up part of trifascicular block, which we'll discuss in lecture 4, but essentially if you've got left axis deviation, right bundle branch block, and first degree heart block, then that's called trifascicular block, and that's a little bit more significant. So do make sure when you see an elongated PR interval, what's the cardiac axis like, what's the QRS complex look like? And like I said, we'll discuss that in more detail in lecture 4. So I'm going to move on now to talk to you about third degree complete heart block. I appreciate that I've skipped second degree, but I will come back to it. I just think it's easier to explain third degree heart block before going into the slightly more complex area of second degree heart block. This is our drawing of the heart again. And remember we said that the AV node is the only electrical connection between the atria and the ventricles. But in complete heart block, the AV node stops transmitting signals. So now we have atria and ventricles which are completely isolated from one another. So we get our sinoatrial node and it's firing off its depolarization as usual, and the atria depolarize, and the signal gets to where the AV node should be, and nothing happens. The signal doesn't get through. So instead of just having this normal PR interval, nothing happens at all. We don't get any ventricular signal necessarily. And eventually the sinoatrial node might fire off again, we get another P wave, and then we get another prolonged PR segment, essentially, because we're just not getting signal through. And so there's no signal that goes into the ventricles. And this will just go over and over again. And obviously, if the ventricles don't do anything, that's not a good thing, and that's how people can die. But meanwhile, while this is going on in the atria, often the ventricles will do something. So we've got our sinoatrial node, we've got our P wave, we've got our lack of signal going through to the ventricles. But we might get another ectopic focus. So a lot of the conducting tissue in the His-Purkinje system has an intrinsic ability to depolarize in its own right, and it acts as a backup, and it will fire off. So even though it's not getting a signal from the atria, it will fire off. And it'll act as a pacemaker, and you get a QRS complex. You get your plateau phase, and you get your T wave. That's the atrial activity with our P wave, and this is our ventricular activity with the QRS complex and T wave. But there is no communication between them. Okay, they're completely isolated, and they just happen by themselves. So that means the atria and the ventricles are completely uncoordinated from one another and act completely independently. So that gives us our clinical features. Our P waves and QRS complexes are just completely unrelated. And I think you have to spend some time looking at the ECG to make sure that's the case, because often they will by chance line up and look like they're related for a beat, maybe 2 beats. But actually, if you look across the whole ECG, you'll see that actually they are unrelated. Now, the QRS complex is a bit variable. If that pacemaker cell is high up, then it may be quite narrow. But if the pacemaker cell comes from somewhere in the ventricular muscle, then the QRS complex might become quite broad. And the PR interval is essentially non-existent, right? It's so variable because there's no communication. It's not just prolonged like it is in first degree heart block. So just to talk about the variability in the QRS complex, it's the breadth of the QRS complex that matters. And it just depends on what cells trigger the ventricle to depolarize. So if we have this pacemaker cell high up in the bundle of His, what then happens is the depolarization of the ventricles follows the standard electrical pathway. And that's good news. And essentially we get a narrow QRS complex with that. Now, instead, you could have a pacemaker cell in the ventricular muscle itself. And this doesn't really use the electrical conducting system very well. So it moves slowly, and that's why I've used dotted lines for a lot of this. It certainly moves slowly going across the other side. And you get, instead, with this slow conduction, a broad QRS complex because it's taking time for the ventricle to depolarize. So why does the QRS complex breadth matter? Well, the cells in the conducting system are good pacemakers. They're developed as electrical tissue rather than contracting muscular tissue. So they are pretty good at carrying on as pacemakers. And that's just very different from the muscle cells, which are designed to contract. They're not designed to be pacemakers. So the ones in the conducting system will carry on working, but the bad pacemaker cells might just stop working. And that's bad, because if you don't then have the pacemaker working in the ventricles, you've got no signal coming from the atria. So the ventricle just doesn't work. And you die, potentially. So the narrow complex in complete heart block is good because it means the pacemaker cells are coming from the conducting system. And the bad broad complexes are bad because it suggests that the pacemaker cells are coming from the ventricle. And essentially it suggests the broad complex is more likely to give up. And so I'd be more worried about that person needing an urgent or emergent pacemaker in the middle of the night. Okay, so it seems like it's about time for an example ECG here. So as usual, I'll pop it up on the screen, give you a few seconds to pause it and go through it in your own time, and then I'll go through it with you. So here it is. All right, so hopefully you've had a chance to go through it. So starting with details, we don't have any obvious details about the patient, but I'll tell you that they've come in with a collapse in this case. From a technical point of view, it's calibrated correctly. You can see the rectangle on that left-hand side of the trace. You can see the rate is probably a bit on the slow side, so there's about 6 large squares between each R wave, suggesting the heart rate is probably about 50 beats a minute. So there's a bit of bradycardia here. And the rhythm, well, it's certainly regular. You can see that there's an equal gap between those QRS complexes. And there are P waves. I'm just going to be a bit coy about that for a second. The axis looks a bit abnormal, doesn't it? So it's positive in lead 2, but it's just about negative in lead 1. So that suggests we've got a bit of mild right axis deviation. And what about P waves? Well, I'm just going to blow these up for a second, and we can see that there's quite clear P waves there and appears to precede a QRS complex. So I think it'd be quite reasonable at first glance, certainly, to say, well, this might just be sinus rhythm. But let's have a look at the PR interval. Okay, so I'm just going to pull up the rhythm strip here, and you can see, well, that's one P wave associated with a QRS complex, but that's quite a different gap there, isn't it? That PR interval, or the PR segment, just the gap between the end of the P wave and the beginning of the QRS complex, is quite a lot smaller there, somewhere in the middle there, and broad again there. So is this just sinus rhythm? Well, I mean, look how hugely different they are. So there's a highly variable PR segment in this case, what I've illustrated, but the PR interval would also be highly variable. And actually, there are way more P waves. Okay, you can see them marching through it, and actually you can see there are P waves probably in the T waves there, and I've just drawn these out at equidistant points. So you can see them, and you can see they're probably buried in that first QRS complex as well. But there is a regular RR interval there. Okay, so QRS complexes, well, actually they're pretty broad, aren't they? So about 180 milliseconds there. So that's something for us to bear in mind. It suggests that our pacemaker site is somewhere in the ventricular muscle. So our drawing on the right. ST segments, well, you might be sort of thinking, oh, well, there's some ST elevation there. And that would be very reasonable, but I think that actually they're just P waves just right at the end of the QRS complex, and you can see it more clearly in lead 2 there. That looks more like a P wave, and indeed you can see them in other QRS complexes later on as well. So don't be fooled by that. Just make sure you're looking at all the leads and seeing whether that is what you're seeing, or whether you're actually genuinely seeing ST elevation. And remember from last lecture, bundle branch blocks, which are essentially what you're seeing in some form with this broad QRS complex, they are causes for non-ischemic ST segment changes as well. T waves, well, there's quite significant T wave inversion in keeping with that broad QRS complex, and we'll talk about that in more detail in lecture 4. So in summary, this is an ECG of somebody who has complete heart block with a broad QRS complex and a ventricular rate of 50 beats a minute. I'd be relatively concerned, particularly with the history of them coming in with collapse, that they are at high risk of having an asystolic pause, and they certainly need a pacemaker just because they've got complete heart block, but they may need one more acutely than otherwise. Okay. So let's just do a quick recap on where we are at the moment. So we've got first degree heart block, which is there's a delay in the AV node, but all the signals do get through. So each P wave leads to a QRS complex. And you've got third degree heart block, where the connection between the atrium and the ventricles, either in the AV node or just below it, is not working, and so no signals get through. So what about second degree heart block? Well, second degree heart block, the AV node is lazy and only transmits some of the signals. We'll talk about that more in a second. So secondary heart block, well, it's actually broken into 2 subtypes. There's Mobitz type 1, which is also known as Wenckebach, and Mobitz 2. And these are quite different, although they're grouped under the same parent category. So in Mobitz 1, what you have is the AV node getting progressively slower. And you see this on the ECG with a slowly prolonging PR interval. So it may start off relatively normal, and then the next beat it's a bit longer, beat after that it's longer still, and longer still. Whereas in Mobitz 2, the AV node either conducts or it doesn't. So you'll have a PR interval that's the same for every beat that there's a QRS complex after it. So with Mobitz 1, as that PR interval gets progressively longer, eventually it gets so long that the AV node never really conducts that signal through into the ventricles, and you miss a ventricular depolarization. And that's quite clearly patterned. So it gets longer and longer and longer, misses a beat, and then it resets. And the PR interval is normal or near normal again, and it gets progressively longer before it misses a beat. Whereas in Mobitz 2, it'll intermittently miss beats. And that might be in a clear pattern, like every other beat or every 3 beats. But the AV node, like I said, doesn't get slower. It either conducts or it doesn't. So the PR interval on the beats that are conducted are the same. And then the bits where the beat obviously doesn't conduct, then it goes until the next P wave. And Mobitz 1 is relatively benign, actually. If I tried to make your heart go fast enough, if I put a pacing wire in your atria, you can eventually reach a point where everybody's heart will start Wenckebaching if you get fast enough. And it's just part of the AV node's safety mechanism to help stop the ventricle going too quickly. Whereas in Mobitz 2, actually that can quite often progress to third-degree heart block. So actually that's a much more serious condition. And that's why it's important to be able to differentiate these two apart. So let's look at Mobitz 1 heart block, the Wenckebach pattern. Okay, so here we've got an ECG trace. And I've got the same ECG trace actually below here on a slightly different piece of paper, but it is actually the same trace. And you can see they're regular P waves, okay? So I'm going to map those out. You can see them here, and they're regular, right? So the gap between them is the same each time. And then there's one here, and you can see that on the lower trace as a change in that T wave. And then there's one here, probably buried in the QRS complex. And then another one. Okay, so they regularly are marching through this trace. So let's now talk about the PR intervals that we see. So we've got our first one here on the left-hand side, and that's at about 280 milliseconds. So it's already slightly prolonged. It gets a bit longer. Now it's up to 400, 800. This one's conducting very far along, so that's taking slightly over a second to get there. And then we get to this next one, and I've coloured this red because we've got our P wave buried in the QRS complex that we saw before, and then we've got another P wave there. But there's no QRS complex between them, so that P wave that's buried in the QRS complex really isn't conducting to create into the ventricles. There's no ventricular depolarization associated with that. So that's a missed beat there. And then we go back, and that next P wave is conducting with a PR interval of 280 milliseconds again. So you can see we've reset that cycle there. And when we're talking about Wenckebach rhythms, we need to count up the number of P waves we've got. So here we've got 6 P waves, and for those 6 P waves, we've got 5 QRS complexes. So we can describe this as being Mobitz type 1 Wenckebach with 6 to 5 block. So how does this compare to Mobitz type 2 heart block? Well, here we have a tracing of what is probably Mobitz type 2. And I'm just going to draw out the P waves for you. And you can see that they are equally spaced apart. And they run throughout the trace. So you've got some regular P waves here. And half of them appear to occur just after a T wave. Okay, so just so you can see them clearly there. Now, these P waves are conducted. So you can see that you've got a P wave followed by a QRS complex. And that PR interval is a little bit long, isn't it? It's coming up towards maybe 400 milliseconds. So it's prolonged, certainly, but they are being conducted. And that compares with these ones just after the T waves, where you can see that there's a P, then no QRS complex, and then another P wave. So those are non-conducted P waves. So you've got 2 P waves for every QRS complex. So this is some form of 2-to-1 heart block. Now, the majority of cases, this will probably be Mobitz type 2 heart block. Now, the problem is that you can't be certain, because it could be Wenckebach. And that's because it's impossible to tell with a 2-to-1 block, because what you don't know is whether you've got a very short cycle of Wenckebach where you would be getting progressively prolonged PR intervals, but that it's only happening over 2 waves. So you, instead of getting just a prolongation each cycle, you get your first beat and then your missed beat. And that could just be a type of Wenckebach that's quite severe. Now, if you had 2 QRS complexes for every 3 P waves, so you had a conducted beat, missed beat, then you'd be able to tell, because you'd be able to say that actually the PR interval in those conducted beats was the same. And that would rule it out from being Mobitz type 1 Wenckebach. But you just can't do that with 2-to-1 block. And so I'm just putting that caveat in there because I think that is quite important. So does second-degree heart block matter then? Well, I think if it's Mobitz type 1, I think it's pretty safe to consider it generally benign. Now, that's if you find it as an incidental finding on a random ECG, say before an operation or something like that, then I wouldn't do anything specific with it. Obviously, if it's an 80-year-old lady and she keeps collapsing and she's missing every 3rd beat, then it's quite possible that she's quite symptomatic from it, and then that might need some more careful consideration. But in general, it's pretty benign, and I don't think you have to do anything particularly with it. Now, Mobitz type 2 is quite different, and that's that second type I showed you, where you're getting intermittent block, but the PR interval when it conducts is the same each time. And that's worse because that can actually rapidly progress to third-degree heart block. That's not the same as Mobitz 1, which is really just probably an overactive form of the standard defense mechanism the AV node has to prevent the ventricle going too quickly. Mobitz 2 is really a sign that there's quite significant conduction disease in the heart. And so generally these patients need a pacemaker, because what you don't want is for them to go all the way to complete heart block. Because the complete heart block traces, like the one I showed you earlier in this lecture, they are in people who've had an escape rhythm that has been generated. There are people where they go into complete heart block and no escape rhythm is generated, and they just collapse and die. And so we want to avoid that for certain. So we really do want to put a pacemaker in people with Mobitz type 2 heart block. So we're coming to the end of the lecture now. I'm sure many of you are happy that it was slightly shorter than the first two that I've put together. We'll just go through the learning objectives and make sure that we have covered them. So the first was to describe complete heart block and what it is. And I think we should be happy that we've gone through that, and that it's a group of conditions in which the connection between the atria and the ventricles electrically is not performing optimally, essentially. And it comes in several forms. And we've gone through and recognized the differences in ECG patterns between those different forms. So you've got first-degree heart block, which is just a stable but prolonged PR interval, compared with complete heart block, where the atria and the ventricles are electrically isolated, and you have P waves marching through and QRS complexes going at completely different rates. And then you've got your secondary heart block, where there are intermittent dropped beats, and they can come as Wenke back, where the PR interval is getting progressively longer and then dropping a beat, or Mobitz type 2, where the PR interval is stable, but you're still intermittently dropping a beat up to every other beat or more frequently in some cases. And we've gone through and described the clinical significance of each form of heartbeat block. Essentially, it gets worse the higher the number. So first-degree heart block is generally benign. Third-degree heart block definitely needs pacing. Mobitz type 2, that worst form of secondary heart block, also probably needs pacing. And the Wenke back form of secondary heart block is probably pretty benign. So again, as usual, I will ask if you have any questions without you being able to directly respond to me here and now, but here are my email addresses and my Twitter handle, and I'm very happy for you to contact me with any questions you might have. And I can't guarantee I'll be able to get you an answer straight away, but I should either be able to find out for you or point you towards a resource where you can find out for yourself. So thank you very much for listening to this lecture, and I hope to see you again for lecture 4.